Next speaker is Swati Khatri from Apollo Multi Specialty Hospital. Her case is saga of stoner, exploring the spectrum of urinary stone disease in a patient.
Your DNB student, please, tell what you are doing there.
Myself, Dr. Swati Khatri, second year DNB resident from Apollo Multi-Speciality Hospital. So this is a saga of stoner. Here stoner is not an addictive person, but a person with a large burden of stone where the large spectrum of disease management has been explored. So this is a 28-year-old male came to emergency department with complaints of shortness of breath, fever and decreased urinary output for 5 days. On examination, patient's outlook was septic and he had a lump which was palpable from right-sided costal margin till upper part of right lower quadrant. And there is a 6 to 7 centimeter size stitched healing surgical wound which can be seen on the diagram which is equidistant from costal margin to iliac crest centered on anterior axillary line and which is corresponding with history of right-sided open ureterolithotomy 7 days back. Here are some lab parameters which are demonstrating that patient was in a septic shock. So this is these are the pre-surgical images where the first control film is showing a radio opacity on the right side at the level of L5 vertebrae, which is suggestive of right-sided ureteric stone as well as left-sided staghorn calculi. And the next one is a delayed image which is showing right-sided hydroureteronephrosis with a cutoff at the level of right-sided L5 vertebrae and left-sided filling defect in pelvic elysial system. So patient was stabilized and then he was posted for the NCCT KUB was done. And here are the axial sections showing right-sided large perinephric retroperitoneal collection with dilated upper ureter and a radio-opaque foreign body inside the dilated ureter. And these are the coronal images which is showing again a large right-sided retroperitoneal collection extending from inferior pole of kidney till the pelvic brim along with hydronephrosis, dilated upper ureter and a radio-opaque foreign body which could be seen extending from pelvis till the urinary bladder as well as left-sided staghorn calculi. Yeah. Yes, sir. So here. And here's this one, this honeycombing. So following which patient was stabilized and on third day, following which patient was stabilized and right-sided PCN tube was placed as well as placement of right-sided perinephric drain. Right-sided PCN was draining approximately 4.5 to 5 liters of urine in a day with perinephric drain which got dried up on second day and a Foley's catheter was draining 450 to 500 ml of day and patient was in a gross negative balance. So after stabilization on fourth day, nephrostogram was done and so I'm not able to play video. नहीं पेन ड्राइव had not brought my pen drive.
इसके अंदर है
नहीं, इसमें ये दिख रहा है. So on fourth day, sir, nephrostogram was done. On nephrostogram, there was right-sided hydronephrosis, dilated upper ureter, and a tube-like filling defect, which is seen in the region of right dilated ureter, with active extravasation of contrast at the level of L5. And sir, cystoscopy was done, which revealed a infant feeding tube as a foreign body, which was removed, and 5 French DJ stent was placed over a guide wire with difficulty. Following which, patient went into hypotensive shock, so further procedure was abandoned and patient was stabilized. And on day 10, post-admission day 10, again repeat nephrostogram was done after removing DJ stent, which again showed right-sided hydronephrosis, dilated upper ureter, and definitive contrast cutoff at the level of L5 vertebrae, suggestive of ureteric stricture. So patient was taken for right-sided laparoscopic ureterostomy. There was epithelialized tract which was communicating ureter with the parietal. The tract was excised and a little amount of pus also came out from the tract, and the ureter was mobilized and the spatulated tension-free end-to-end anastomosis was done over a guide wire. And during the same sitting, left-sided, this is a final picture of end-to-end ureterostomy. During same sitting, left-sided DJ stenting was done, and patient was discharged, and patient was admitted again for left-sided PCNL after a period of 4 to 6 weeks. And since we could not retrieve the upper calyceal stone with the lower tract, so another puncture was made and complete stone clearance was achieved. Patient was doing well post-operatively. Then he was discharged, and again he was brought back to emergency on day 10 with complaint of left-sided ureteric colic and hematuria. So the angiogram was done, and which showed contrast extravasation in the territory of the left lower pole, and selective angioembolization was done, and coiling could be seen occluding the vascular injury. And hence the story started 3 months back, and the patient now is stone as well as stricture free after passing through series of events. Thank you.
So long story. Any question from the audience?
क्वेश्चन पंद्रह
Yes, sir.
Take home message.
Yes, sir. Yes, sir. It was in the ureter. Yes, sir. Radio opaque foreign. Sir, from the, it was placed as a DJ stent only. Both ends were cut open and it was inserted as a DJ stent only. One in the pelvis and one in the bladder. Bladder, yes, sir.
What you have told when you have done ultimately the ureterostomy, maybe laparoscopically, you said that there was pus coming out. So, and there was, in fact, in the CT scan also, or picture what you have shown, it is multi-septated, loculated areas were there. So it was supposed to be pus, and the total count was also very high. The patient was in septic condition, something like that. So in presence of pus, will you go for this ureterostomy at all? Or you will drain the pus, the loculi, all the loculi has to be totally disrupted, and the whole pus has to be drained first. And then leave a drain, wait. There is no hurry in going for ureterostomy or stricture. Because in presence of infection, if you go for this ureter anastomosis, that's not the right approach. So that is one thing I wanted to ask you, why you have done. The moment you have found there is pus, and if you do this anastomosis, it is again going to open up again.
Sir, initially patient was stabilized.
And why this nephrostomy? Why you have said that this, I could find one nephrostomy sheath or ampla sheath I could visualize probably.
Sir,
Why this nephrostomy was done?
Sir, as patient was in septic shock, is hemodynamical, the vital parameters are also not, he was not hemodynamically stable. So we placed right-sided PCN under ultrasound guidance at bedside only. And following which patient improved hemodynamically. And then we took him for definitive management. Once patients settled down, all septic parameters settled down.
Yes, that is the most important thing. You will have to drain it first,
Yes,
and
sir.
leave the drain, wait, there is no hurry. Then how comes this hematuria or that for which you had to go for this embolization?
Sir, that hematuria happened following left-sided PCNL. Patient, after 1 month.
Course,
On the it was on the left side, the PCNL on the left side. What about this right side? What happened? And wait. Huh. No, laparoscopy. During laparoscopy, she said that there was drainage of pus also.
so the presentation was a little bit different. Probably there was no pus during the anastomosis. Because during the anastomosis, you find pus.
Yes, that's what I wanted to say. That if there is pus, you should not go for this primary anastomosis. Just drain the pus and come
Resection,
out.
if you find pus, better not to do anastomosis.
Kidney was draining. What is the hurry in doing?
Yes.
You can leave the patient,
Yes,
wait
yes.
for 3 months,
Yes.
2 months. All
And let the
inflammation
stricture be
subsided.
developed. You drain pus. If the kidney has been drained by nephrostomy, if necessary, you put a local
10
drain
days
also.
You
Drain
can
the
control
area.
infection, but not inflammation.
Drain the
Inflammation will be
area.
there.
If there is pus, drain the area, and if necessary, nephrostogram. All right, nephrostomy tube. Wait,
Sir, videos.
and then let the stricture be developed, and then you will tackle the stricture later on.
This is our first nephrostogram. Yes, laparoscopy. Yes. And sir, repeat nephrostogram video I also have. Definitive contrast cutoff. And sir, this is a cystoscopy video which is showing infant feeding tube which was inserted as a foreign body. And sir, last one is angiogram. Sir, actually right-sided open ureterolithotomy was done at a peripheral center by gynecologist who did open ureterolithotomy and then he placed.
Suppose this patient had come to you primarily
Yes, sir.
And you as a urologist, not forget about the gynecologist.
Yes, sir.
What surgery would you have done?
Sir, I would have done right-sided open or laparoscopic ureterolithotomy, and followed by left-sided PCNL.
Correct. No, she's
So
correct.
such a large stone burden, that's why. Large stone burden.
We have done URAs in impacted stones, and some part of the stones they always always remain adherent to the wall of the ureter itself. That is what I have seen. And so, if I am allowed, then in impacted stone, particularly for a pretty long time, the impaction is there, I will prefer not to go for URAs. Because in many cases I found that there are some bits of fragments of the stone which is lying quite densely adherent and impacted in the wall. So I don't know what is others' opinion. Ultimately, some of these stones, some of these cases where this URS has been done and with difficulties the stones has been removed, many of these cases they will develop stricture.
What is the size of the ureteric stone?
So it is of size of a vertebral height only.
More than 2 centimeter, I think.
Yes, sir.
So if the stone is, impacted stone is more than 2 to 3 centimeter, better to laparoscopically or open rather than endoscopic management, because many cases they come and with the stricture and
In case of a large stone, you can go for retroperitoneoscopy. If Malay remembers and Supriyo, in fact, we used to do quite a lot of this retroperitoneoscopic stone ureterolithotomy, and that becomes easier if the stone is very large.
Definitely. If you have laser in hand, you can manage larger stones, because in case with the help of your pneumatic lithoclast, the chance of the fragments going inside the wall of the, because the wall is very much in impacted stones, the wall of the ureter is little bit inflamed, damaged, very thin, and there is every chance of, Sarah was telling that, every chance of puncturing the fragments of the stone inside the wall, and even it go outside the wall. But laser will help, but definitely it has also limitation. Laser. No, I am not telling in that situation. In general situation, laser helps than your pneumatic lithoclast. If it is more than 2 centimeter impacted with adenoprosis, better to open or laparoscopic better. If you cannot see the stone due to granulation tissues, that is different situation. So if it is difficult, definitely go for open. If it is difficult, rather than coming the patient again and again with the strictures and blaming you, in many cases they come here and there with the blame.
What is your logic against push PCN?
Push from where? You can push it from the Pew junction. You cannot push it from the view junction. If it is near the Pew junction, you can push back and do the either ESWL or do the RIRS, whatever may be. No, we are telling about the impacted large stone. We are thinking about large impacted stone. Impacted stone? Yes, impacted large stone. Yes. Pushing the stone intact is very difficult and dangerous. If even impacted blast stone in the new junction, you can. Sometimes if you do the measure, it will go up. It will be automatically pushed up, and you have to do RIR or in the same thing, whatever may be. Small stone, small impacted stone, you can push it. But the large impacted stone, push it difficult. Okay, thank you very much.
Thank you, sir.
We are concluding our scientific session. Thank you all the senior teachers again and PGTs and my colleagues.
কপি করে নিও ওটাকে